Well, welcome to ESGX Live, the community for information and education to inspire collaboration and action to help build a better and more resilient economy and indeed society. With me, Nigel Lake in New York, and my co-host Paul Herman in San Francisco, and our producer Nick Gower, who is ranging around the country. I'm not sure where he is today, but we're thankful for his support always. A very good morning to those of you who's joined us in the APAC region. Good afternoon to those of you in the Americas, and thank you if you stayed up late in Africa and Europe. Today, we have Carolyn McClanahan to talk about the opportunities to use community healthcare as another way to drive improvement in the American healthcare system. And of course, we also have our Green Jobs Report. But just before that, as a little bit of introduction, I wanted to share a little bit of perspective from a foreigner who's lived in the US for the last 5 years. Firstly, we're obviously embroiled in this COVID crisis. There are now 33 million cases. That's up about 40% since last month's Green Jobs Report. And I think the growth in case numbers globally remains hugely concerning. We've passed 1 million deaths, which is tragic. And the US accounts for 1/5 of those deaths globally. A lot has been said about that. It's also interesting to look at another big picture view of American healthcare more broadly, which is simply life expectancy at birth. And as you can see here, the US is the orange line overall, not quite the far right of this chart, sandwiched between Cuba and Lebanon, behind almost all of Europe and a variety of leading Asian countries and countries like Australia too. Another version of this, which I came across in preparing for the discussion today, was these charts, which show firstly life expectancy in the US about 50 years ago, 1972, where in the left you can see the US is the same green as Canada and the European region and Australia and New Zealand. Wind the clock forward 5 decades on the right, and Canada and Europe and Australia and New Zealand and indeed Japan have all accelerated ahead of the US, which is now in a group with Latin America, China, and parts of the Middle East. And of course, over some recent years, US life expectancy has actually declined. One of the really shocking things, I think, to most people is just how much the US spends on healthcare. This shows healthcare as a proportion of GDP, and the results, where this is not a chart where you want to be in the top left-hand corner with higher spend and lower life expectancy. These figures are just averages. And of course, if you dig beneath this, there's perhaps even more significant variation between different demographic groups. And these figures show that if you're in the bottom quartile, you have a whole decade less life expectancy as a 40-year-old than if you're in the top quartile, I should say. So with that, by way of very brief introduction, I will hand over to Paul Herman to introduce the show. Please do introduce yourselves to each other in the chat. Join the discussion there. If there are resources you think are useful, please post them there. And please do ask questions. If you can pop them in the Q&A, they're easier for us to keep track of. But all questions are good questions, and we very much appreciate them. And with that, I'll pass over to you, Paul, to introduce today's show.
Great. Thank you, Nigel. And delighted to have all of you with us today on ESGX. Nick Gower is back in California and safely tucked in the Santa Cruz Valley. So welcome back, Nick. And Nigel, thanks as always for the global overview and how we have a lot of work to do on healthcare and green jobs, and how green jobs can help produce the talent and connect the job opportunities. So as usual, monthly, Amir Khalegi, under the guidance of Dr. Scott Fullwiler and Dr. Fadhel Kaboub, is going to, working with HIP Investor, is going to share with us the latest actual data from the Jobs Bureau of Labor Statistics and connect those to who's being more or less sustainable, as well as in higher or lower contact industries. And then we're going to take a deep dive into the financing of healthcare and where job opportunities lie in healthcare, which is about 1/5 of GDP. More than $1 out of $5 of GDP goes to healthcare. So when you get sick, you actually add to GDP. And so the challenge is how to keep people healthy, to be productive and innovative, to have a higher multiplier factor on our economy, on our lives, on our health. And when 1 out of 5 people get sick, that's why we have insurance. When 1 out of 5 people get sick, and if you have a family of 5 people, there's a high probability of one of them having a persistent health problem over time. So Dr. Carolyn McClanahan will do a deeper dive into that, and then we'll bring everybody together for the panel conversation. So Amir, why don't you come on screen? I'll fire up the PowerPoint for us, and excited to review the latest of the Green Jobs Monthly Report.
Perfect.
And a reminder to everybody, please join in the chat box or ask your questions in the question box.
So thank you everybody for joining our 6th consecutive Green Jobs Report. So for those of you who are just joining us, or for those of you who need a reminder, our Green Jobs Report connects companies from the HIP Investor's Human Impact and Profit Rating and maps it to industries. The Human Impact and Profit Rating is based on performance, products, and management practices that include detailed metrics, especially focused on health, wealth, earth, equality, and trust pillars that are made for sustaining people, planet, and trust. So for our monthly Green Jobs Report, it focuses on measuring the direction, momentum, and changes towards a greener, more sustainable economy and the related jobs. So the greenness of industries are varying. They are in 3 different tiers. Highly rated green industries, examples of them would be wholesale distributors of medical products, recycling services, cleaning compound manufacturers. The medium, less extractive rated industries would include pharmaceutical manufacturers, hospitals, and insurance agencies. And the most extractive, lowest rated industries include oil and gas extraction and casinos. So a common theme between our 6 reports is that greener industries were the most resilient to job loss from the COVID-19 crisis. This still remains the fact, right? So looking from February to July, greener rated industries have proportionally lost the least amount of jobs as compared to the lower tiered industries. So the lowest tiered industries from the graph we can see has lost around 11.5% as compared to February, whereas the greenest rated industries lost about 4.55% of employment since February. So taking a month-to-month view, starting from February, extractive industries were seen to start regaining their jobs, but they are appearing to regain at slower rates due to the lessening of employment change. From May to July, we saw an increase of employment of 4.5 million, but from June to July, that substantially decreased to 1.7 million. And this is reflected through the percent changes that we see from comparing May to June and June to July. So we see here that for the extractive industries, they reduced by a substantial amount, but the point that has consistently been brought about is that greener industries were more stable to the more stable and more resilient to the COVID impact, and we can see that they weren't severely impacted by this reducing of employment change. We can continue. So no, go back one. Sorry. So this is taking an alternate look at the products and services ratings, which is a pillar of the human impact plus performance scores. It obviously looks at the products and services that companies produce specifically. So what we had seen is that industries with extractive products have been slower to recover in terms of employment. So this is pointed out by looking at the extractive industries from April to May. They were still being reduced in employment, whereas the net positive industries from April to May started retaining employment. Remembering that the change in employment from June to July was less as compared to May to June, still the net positive industries regained more jobs as compared to the net extractive industries. As indicated, the net extractive industries are the bars seen in red and yellow. Another point that's emphasized is that green jobs have paid more. And this has been consistent throughout the 6 months. And remembering back to, last year's not last year, but last month's green job report and the month before that, we were seeing record amounts of income increase due to the destruction of low quality jobs. I believe that in August we had a 4.7% increase in average hourly earnings, but again, this was due to significant the significant destruction in low quality jobs. But as we can see now, the average hourly earnings has begun to normalize. And over the month of June to July, average hourly earnings increased by 0.13%, which is, a normalized rate of change. But with that being said, even with that change, greener industries increased by the largest amount as compared to net extractive industries. You can see here that in July, the average hourly pay for green industries was $39, around $39, and this is an increase of about 0.66% or 2/3%. Slightly extractive industries, their pay decreased by 0.11%, and the extremely extractive industries increased by about 0.11%. So this being said, green jobs consistently have paid more, but even in normalized conditions, they had the highest increase in pay. Moving on to the high contact sectors. So high contact industry sectors are occupations which require work to be within 1 arm's length, and is opposed to low contact industry sectors which allow for social distancing. For our analysis, we mimicked the St. Louis Fed's analysis of high contact and low contact industries. And what we had found is that rating these industries that were contained in the high contact and low contact and high contact, industries that were rated below 30 on the human impact and profit scores had a higher loss proportionally in employment as compared to the industries that were above 30 HIP score. So we can see here, right, in high contact industries, industries that were rated below 30 had around a 14% decrease, whereas industries that rated above 30 had an average of 10% on decreases since February. The same story is had with low contact industries. So below 30, we can see here that there was around an average of 9%, whereas above 30, there was an average of a reduction of 5%. So the key takeaway here is that green jobs remained more resilient to job loss when compared to extractive industries. And this was regardless of whether the industry was high contact or low contact. It was the same story all the way around. So our edition for this month's Green Jobs Report is focused on healthcare. And for this portion, I did a deep dive on the Occupational Employment Statistics Survey and did an occupational analysis of the primary care industries, focusing on the primary care industries. As a quick conceptual layout, so first we'll display data at the healthcare supersector, so healthcare and social assistance. Then we break it down to the 4-digit NAICS codes for the industries, which include industries at the level of offices of physicians, outcare patients, general medical and surgical hospitals, and a few additional ones that we'll see on the tables proceeding. And we link together their HIP scores, but we also focus on their occupational groups. So the top employed occupational groups within each of the healthcare industries are healthcare practitioners, healthcare support occupations, and office and administrative support occupations. The data that is paired with these occupations will be average hourly earnings and average annual earnings, their employment count, and the percentage of industry employment for that given occupation. So the percentage of employment for healthcare practitioners within the offices of physicians, and then, another example, the percentage of healthcare support employment within the total employment of offices of physicians. So with that being said, we can look at the examples of jobs within the occupational groups. So as alluded to before, the top 3 occupational groups within the healthcare industry are healthcare practitioners, healthcare support occupations, and office administrative support occupations. Examples of jobs within each were listed below, but for example, right, looking at the healthcare practitioners occupation group specifically, we see that occupational care industries generally provided highly rated products and services, yet rated lower in other HIP pillars. Focusing on the 2 columns to the right, we can see that, for example, offices of physicians rated 30.3 in the human impact plus profit score and had a score of 60 in products and services, whereas medical and diagnostic laboratories had a HIP score of 35.4 and a product services of 70. The point that I'm trying to allude to is that we often say that green jobs pay more, but we're only focusing on the wealth pillar. And that's not the only pillar that is included within that calculation, right? We have health, wealth, earth, equality, and trust. So looking at these industries such as offices of physicians and these primary care industries that provide healthcare, due to the limiting of services, health services through the payer system, it affects a level of inequality that causes a lower human impact plus profit score. We can see these in the following tables, but what to focus on right now is that we can see here, right, that there's a lower HIP score for offices of physicians, and for healthcare practitioners, they have the highest hourly and annual wage. But this can kind of be, deducting this reasoning. The healthcare practitioner educational requirements has a wide array of requirements. So in offices of physicians, the main percentage of employment would be, your physicians, your dentists, your psychiatrists, and these all require doctorate degrees, which is correlated with higher hourly and annual wage. But this offices of physicians, offices of other healthcare practitioners and such also have a good proportion of nurses, speech language pathologists, therapists, etc., that require a bachelor or master's degree for these occupations. And it also has a proportion of on-the-job training related occupations such as health information technologists or medical technicians as well. So this is obviously heavily affecting the median annual wage. But again, a key takeaway here is that the HIP investor score, the HIP impact plus profit score, also has pillars that are taken into account other than pay and wealth. It also looks at the services and equality of those services that are provided to the entire community. So now let's look at the occupational breakdown of healthcare support. So healthcare support would include jobs such as like health home aides, mental health aides, medical assistants that perform the medical tasks for like early detection. They might administer shots. They might take your blood pressure or very routine illness detecting methods, or for lack of a better word, right? So something to be noted here is that in the primary care industries, if we're looking at both the super sector and the subsector of healthcare support and social assistance and the ambulatory healthcare services, the proportional average of employment for healthcare support is around 28%. And for the primary care services, they're all below average by a very significant portion, right? Offices of physicians, which would be obviously the industry that is most involved with primary care, rates 10% below the average of the super sector itself. And something that we want to promote, and a topic that will be a great deal of the discussion preceding this analysis, is that healthcare support occupations has a great capacity for growth. And an increase in these healthcare support occupations can provide beneficial services on focusing on in-need communities. And so, for example, community support. And these healthcare support occupations also require short on-the-job training, which allows for easily acquiring a capable labor force that would have those multiplier effects that Paul had mentioned earlier, right? These rippling benefits that not only can support the worker in providing a livable wage, but also supports the members of the community in the detection of early onset illnesses, or improving life expectancy, as Nigel alluded to in the beginning. So with these types of practices, there is a labor force that is willing to work for these livable wages. And with promotion through policy, community involvement would have, a multitude of beneficial effects rippling throughout the economy itself. But regardless, right? So this is the point that is kind of shocking, right? Is that in terms of office and administrative support occupations, the primary care industries, as seen from the percent total of employment column, all mostly rate above the average of the obligatory healthcare services, right? They rate above the obligatory healthcare services by around, offices of physician by around 8%. But for even the super sector of healthcare and social assistance, it averages around 13%. So it more than doubles the amount of occupations that are primarily dedicated to ensuring the payer system through billing and accounting. But again, it would be unfair to say it's only occupations for that, but it is a great proportion. Other occupations that go into the office and administrative support category would be medical secretaries or medical records who keep track of health the client's health information as well. But this is something that, passing it on to the discussion to Dr. Carolyn McClanahan, she'll go into much greater detail on this, but we can see how the averages in our primary care systems it's double than the super sector itself. So there's a great mass majority of these jobs that are going to supporting the payer system, whereas the service beneficial jobs such as health support aides, mental health aides, home health aides, people who are able to readily go out and check on the community, are substantially lower than the actual healthcare sector as a whole. And these are true. These are the numbers by the BLS, and sometimes it's just shocking to see. But yeah, they're there for everybody to see, and hopefully that sparks the discussion for our next panelist.
Well, Amir, thanks so much for taking this deep dive, and especially going into the healthcare sector, which is 20% of GDP of the economy. And it's amazing to see just the percentage of jobs that are things like data entry keyers and accountants and and the like. So that may become part of our discussion as well, is might there be some tools, automatic tools, artificial intelligence that helps billing and processing so that more money can get freed up for healthcare, and then others trainable healthcare jobs, which I think Carolyn may head on as well. So thanks for providing that really rich and deep look, as well as the showing that the economy is more resilient with greener jobs and higher paying with greener jobs. Carolyn, welcome. It's so special to have you here. Thanks, Amir. Come back at the panel. It's so special to have you here. And you're a doctor, but a different doctor than Scott Fullwiler or Fadhel Kaboub are. You're an actual medical doctor. So we'll try not to get sick while we're together, but we know you'll be qualified to help us. And you're at the intersection of health and wealth because you're a financial planner as well. So it'll be really exciting to hear as you share sort of the lay of the land on how to pay for healthcare and all its forms, and which part should be government, which part should be individual. Is Medicare for all a helpful policy? Is there a better approach to it, especially with the presidential debate tonight? So I'll tee it up for you, but thanks for being here, Dr. Carolyn, and intersecting health and wealth, and how we can hopefully become healthier and wealthier at the same time.
So thank you so much for having me here. Paul and Nigel and Fadhel and Scott, you guys have, I've watched a lot of your work, and Fadhel and Scott both helped me with a book club I ran on MMT on Stephanie Kelton's book. And I'm so excited to have a crew of people who are trying to make a big difference with green jobs, job guarantees, and how we're going to pay for it all. And I got involved in this world back in 2012 when I met Stephanie Kelton. I heard her talk about MMT, and I'm like, oh, that's the way to pay for our healthcare system. And I actually wrote a healthcare proposal back in 2012, and it's been in and out working with politicians on my healthcare proposal. And you know how politics goes is some days they get excited and other days they tell you, oh, it's not feasible. So I think we're back to the point that fixing healthcare is feasible again. And part of that's going to be the outcome of this election. So what I want to do is share with you guys a little bit about how, and I think I just shared my screen there. Can you guys all see my slides?
Yes, we can see them.
Great. And so I just want to share with you guys the, we'll go through, hold on, I got to get back. For some reason, I can't get to my slides. So hold on.
Feel free to ask your questions in the chat box or the question box. And
yep, please ask me questions throughout, and we'll and I'll answer them. I'll go through this real quick, and then I'll answer the questions. So what I want to cover first is all the discussion around healthcare has been over how are we going to pay for healthcare. We've had years and years of arguing about Medicare for all versus the Affordable Care Act versus this elusive free market care that somehow can cover pre-existing conditions when they've never come up with a free market type of care that would do that. And then, we're leaving out an important part of the discussion is fixing the healthcare system. And so I'll go into that. And then I want to cover my proposal, which is a very, very short discussion of my proposal called Primary Care for All, and then how this translates into green jobs. So first, let's talk about payment system reform versus healthcare reform. So we've had these arguments, and part of the problem in our country is that we've been so focused on just fixing the how we pay for healthcare. And to me, it's like using monetary policy to fix the economy. And so since I'm speaking to a lot of economists here, you guys know that what we really need to fix the economy is fiscal policy. We need Congress to do things like create jobs, fix infrastructure. And so with healthcare, yes, we have to fix how we pay for the system, but the reason the system is so expensive is because our healthcare system is broken. Our healthcare delivery needs fixing. And so part of that's going to be, you guys were talking about like the billing system. If we just had a single billing system, it would save a load of money. If we had one electronic medical record instead of all these dozens of health records that are built around billing instead of healthcare, it would save a ton of money. So there's so much we can do to fix the healthcare system. Part of the problem in this country and why we haven't been able to agree on healthcare, on how to fix healthcare, is half of this country is what I call individualists. So these are people who are the bootstrappers, thinking everybody needs to figure it out themselves and they should go get jobs and they should go get healthcare, versus that half of the country is collectivists. They understand that providing a basic care for everybody is good for the economy. It's good for capitalism, for people to be healthy. Healthier people are more productive. And in Europe, where in all other industrialized nations have universal health care, and in Europe, the mentality is more of a collectivist type system. So everybody understands the need for basic health care. And so when you talk about Medicare for all, you just can't flip a switch of our current payer system going to Medicare for all. And I know Stephanie Kelton's talked about this a lot. There are a lot of jobs that would be lost. And where would those people go? Right now, there are 1.8 million jobs. This is just from a very recent study in Health Affairs, that it's dedicated to billing, just billing. And if we had a simple billing system, all those jobs would go away. And, while we fight about all this, who's going to pay, the system continues to fall apart. Part of the problem is our country, the United States, has a very broken primary care healthcare system. In all other countries, primary care is well funded. Most other countries spend at least 10 to 12% of healthcare dollars goes to primary care. And in this country, it's about 5 to 6% goes to primary care. 70% of the population only needs primary care doctors. Most people do not need to see specialists for their simple things like basic hypertension, diabetes. All those simple things should be cared for early and often by good primary care doctors. And the other problem we have is our fee-for-service system. And so doctors are paid more to do more. And so specialists hold on to a lot of problems that primary care doctors should be taking care of, and that they should be working together with the specialists to take care of these problems. And, right now, we have a national community health system, and most people don't even know about this. Our community health system, it's a patchwork of basically primary care practices that are either federally funded or funded through charity or privately funded or state funded. And right now, the community health system takes care of about 30 million people, mostly low income patients. So people think about these as places for the poor. And they provide primary care, dental care, mental health care, vision care. Some of them serve as places for opioid addiction centers, and they do it on a shoestring budget. And there are a number of primary care community health centers that just do fantastic work, and at an average cost of about $1,065 per person per year. So that is pretty darn cheap when you consider we spend $3.5 trillion on healthcare. A third of that, which is almost a third, is wasted on overhead and administration. To spend for the entire country, if we actually dedicated $1,500 per person per year to fully fund community health centers, it costs us almost $500 billion. That sounds like a lot, but that is a drop in the bucket to take care of what 70% of people need and a lot of other issues. And so the other problem that we have is healthcare is so far behind in use of green technology. Only through the coronavirus pandemic now have we gotten the ability to use telemedicine. We've had telemedicine available forever, but states fight about using it. There's turf wars over using it. Medicare didn't want to pay for it. And now they're like, oh, everybody needs to use telehealth. Well, it's about time. And because that's a very green way to deliver care. The other thing that we need to do is have community health workers. A lot of older people and people without resources to have the internet, to have good broadband service, to do good telehealth, they can't use it. So community health workers bring the care to the people. And so if we had a fully funded community health system with ample community health workers, these could serve as centers for preparedness for pandemics, epidemics, bioterrorist events, in addition to providing that basic primary care everybody needs. Now, so what is a community health worker? People ask, well, I don't know what that is. So many other countries are way ahead of us. And Africa makes extensive use. All the countries in Africa make it, I sound like Trump saying all the countries, most of the countries in Africa make extensive use of community health workers. And these are lay people that are within the community. They live in the community where they work. They have the same life experiences, socioeconomic statuses, and same languages as the patients they serve. And so they act as patient advocates, they connect patients to services. And we have some very good community health worker programs going on in the United States. Specifically, New York has a great community health worker program. Pittsburgh has good community health worker programs. We know these work. We could expand these throughout the country and provide many more services to people. So how does this translate into green jobs? I think you guys are seeing it already. There's such a huge need for care in this country. We have 23 million people over 75, that it's much better for people to be aging in place, as we've seen with the coronavirus pandemic, that when you warehouse old people in nursing homes, then they die in the droves. And we know, we already knew this happens because it happens with flu season, but with coronavirus, it's much more, it's more friendly, it's more humane for people to remain in aging friendly communities, and the use of community health workers could do this. We have 53 million people with serious disability. 30 million people have unintentional injury. So if you have that massive car wreck and all of a sudden you're sent home from the hospital and you don't know how to get to your doctor's appointment, you don't know how to coordinate your care, that's what a community health worker can help with. 4 million babies born each year. Mothers could use support with nursing, how to nurse and make certain there's doing their well baby checks, guard against postpartum depression. And then all the people diagnosed with cancer, 2 million people a year, 2 million people a year diagnosed with strokes and heart attacks, that they could use this help when they're getting through their initial bad illness to connect them with the services that they need. So that's what community health workers could do. And the community health centers could help stem the tide of our major diseases like diabetes. You have 100 million people with pre-diabetes or diabetes, 100 million people with hypertension, 170 million people are overweight or obese, 50 million people with mental health issues. I mean, we have this huge underlying need for primary care. And by having a community health center where we could provide group education, we could do education through Zoom. There's so many services we could offer cheaply, effectively, and in a very friendly manner to help people get the care they need. So how many community health workers would we need? University of Pennsylvania did a study. They have a great program where they have very high need patients, people who ended up in the hospital all the time, high cost of healthcare. And each community health worker was assigned 55 patients, and there was one supervisor per 6 community health workers. So if you did that out, and I calculated how many high need patients do we have in this country? And I was fairly conservative with my numbers, counting towards higher numbers, that 80 million people would have high need care. And so that would translate into almost 1.7 million community health workers if you counted a 7-member team. And then you have 34 million people who had sporadic needs. So those are your mothers, new mothers, people who have been in accidents. So people who just have short-term issues. And so we need another, so you could have, that community health worker could care for more patients. So they could have like 1,000 patients per 7-member team. And so the total number needed is about 1.9 million. And I just think that's pretty nice correlation of there'd be, if we got rid of our crazy billing system, that's 1.8 million jobs. Well, we need 1.9 million community health workers. And again, community health workers don't have to have extensive training. They just have to be good people and want to help their community. So how green is this? I mean, I think it's obvious. We need to change our healthcare system move it from being doctor-centric, where a ton of people have to go to a doctor's office and be exposed to other illnesses, to where the care comes to people. So it reduces travel for the patient. It improves productivity by keeping people healthier. We're using telehealth, so that's green because people aren't driving around to get to places. We have a healthier workforce. It facilitates aging in place. There's just so many benefits to this, and that will translate into better jobs for other people because they have their base of healthcare served. So I think I covered that in a nutshell, and hopefully we have lots of good questions. Let me look at the question bank now.
Questions are starting to come in, Carolyn. So thanks for that overview. And it sounds like if you take the full US population, I had thought like 20% was the high need. According to your calculations, it's 24%. So it's like 1 out of every 4 people has a high need. Does that sound like the right assumption to make?
I would guess, and I think my numbers are maybe a little high because I wanted, you know, there's so many crossovers between people who have like serious diabetes, serious heart disease. A lot of them are the same people, so it's really hard to break those apart. So 20 to 24%, I think, is a fair enough assumption.
All right, still 1 out of 4, 1 out of 5, similar to the number of, you know, children who are in poverty. Is
right.
1 in 4, 1 in 5 as well. So here's a question from Dave Airy in the audience, and audience, please join in and ask your questions in the question box or chat box. So would Dave's internal medicine doctor and her colleagues who currently work in a for-profit clinic, would they become employees of a community health center? And then if so, would those incomes for the doctor be lower, the same? How does that get treated in the way you're thinking about it?
Right. And so the way that this would work is we would need to pay doctors very well. And just like we do in the private system. So a lot of doctors would love to trade having to work in a for-profit system where their patients don't always get the care they need, and they're having to deal with insurance companies and all those administrative hassles, to moving towards a community care system where they could just provide good health care. These places would have to be very well funded, nice places where people would want to go for care. And so my ideal, you know, and this is where we can get into the arguments of, do we just want a totally public system? It's kind of like in England, private payer and private providers, or do we want public-private competition? I am more of the ilk that everybody needs competition to be their best. So government can provide really good care and keep the costs low and serve as competition towards private care to make them be more honest and serve us better at a lower cost. And likewise, private competition would force the government to have to perform. I think competition is a good thing. And then I think having a nonprofit competitor such as the government would set the bar and keep costs lower. Now, would your doctor have to work for just the public clinics? No. And there's a movement in family medicine called the direct primary care movement. It's already happening. The number of doctors that are providing care just on a cash basis system. What people don't realize is that primary care is really not insurable anyway. We shouldn't be providing primary care through insurance. Insurance is meant to cover high cost or rare illnesses. And you don't go to use your car insurance to get your oil change or when you have a flat tire. Primary care should be paid for directly or provided. And my ideal is we provide all primary care as a public service, and that if people want to go to and pay for a private doctor, they can go do that, but it's not going to be covered by any insurance. So it gives your doctors choices, gives the patient choices.
Okay, great. And Carolyn, can you stop sharing the screen and then our faces will
Oh, so sorry. Yep.
yeah, no problem.
Something was wrong.
No
There
problem.
we go. Bring everybody in.
And okay, so Tim Mock has a question: how to find listings and ratings of local CH services?
Local community health services. Yeah. So the National Association of Community Health Centers has a list of community health centers in your area. You could probably just also just Google in your area community health centers. I know in Jacksonville we have quite a few, and so they're hidden gems in communities. But again, the sad thing is community health has been so poorly funded. The Affordable Care Act provided ample funding for community health care and for public health care. And when the when the Republicans took back the House in 2010, they had to bargain away all the budget. And so, of course, the first thing that got cut was all that great funding for primary care and community health centers and public health. So we need to reinstill that.
Okay, yeah, so it seems like there's, and Fadhel and Scott, feel free to join into the conversation too. It seems like rural healthcare, low populations have been eroding, and
Yep.
we did an analysis for COVID when COVID started to look at bed capacity. The interesting thing is bed capacity or ICU capacity can be high in some rural areas, so they've built out sort of higher capacity for when there's a stress to the system, and urban systems don't have over capacity. They sort of assume a sort of recurring illness and so there's less tight capacity, but the number of doctors, even though the beds are high, the doctor percentage is low, or the healthcare support staff is low. So how would we accomplish that going forward?
Oh, that's where telehealth would be fantastic. So I've worked both in urban and rural areas. And, the problem you have in rural areas is the support is so poor. Doctors don't want to practice in those areas because they can't always get the care that their patients need in a timely fashion. And so with telehealth, it would be fantastic. You have primary care doctors, community health workers in the community, and when you need a specialist, and that's going on now, and hopefully we'll see that blossom more, using telehealth to bring the specialist to the patient instead of the patient having to travel to a specialist that's not there.
Got it. All right. And all right, so we can get into it. One more question, and then we're going to get into it about like Green New Deal, Medicare for all, primary care for all. You mentioned an organization where doctors are moving to cash for services as opposed to insurance.
Yep, and it's called the Direct Primary Care Movement. And so you could just Google direct primary care, but the American Academy of Family Physicians, which is the organization that family physicians, their support organization, basically helps promote direct primary care, because they realize that primary care really shouldn't be covered by insurance either. And basically cash it, they used to call it concierge medicine, and concierge doctors used to charge a lot of money, but now there are direct primary care practices that charge very reasonable fees for basic primary care.
Got it. Okay, so you're in an active Twitter battle on Medicare for all. What's the challenge of Medicare for all, and what are alternatives? And then Fadhel and Scott, feel free to join in.
Well, people talk about Medicare for all like it's going to totally fix the problems. And like we've already discussed, more of the bigger issues is fixing our healthcare system. And so we can do things like single billing. We can have one nationalized electronic medical record. We've got to work on fixing the healthcare system. The issue with Medicare for all is that people think it's totally government run, and it's just the government paying for healthcare. There's still going to be private providers. You know, like in Twitter today, I was getting reamed. It's like, well, do you believe in privatizing any of medicine? We think it should all be publicly funded. I'm like, well, Medicare for all doesn't fit that. And it's like, they didn't understand me. And so what we have to understand is any type of health care system would work. We need to pick one and go for it. Countries have private payer, private provided. Germany does that very well. Countries have publicly paid, privately provided. That's Canada. Publicly paid, publicly provided. England. They all work. We just have to pick one that's going to work. And Medicare for all could work, but the fact that we can't agree because of that collectivist, individualist mentality in this country, it's going to be very hard to get it passed and make it work without it being basically sabotaged like the Affordable Care Act was. I mean, if you think about it, the Affordable Care Act was originally a Republican healthcare plan. And just because it was passed by Democrats, that, you know, the Republicans made this decision to sabotage it because they wanted their plan in place. But they don't have a plan.
All right. So,
well,
comments?
Yeah, I have a couple of comments and maybe a question for us to consider, especially for Carolyn, who's the expert here. A couple of observations. So we've been talking about Green New Deal, green jobs over the last few webinars here in the Green Jobs Report. Just a point of reference that, you know, we're not really trying to invent anything new. We've done a lot of this stuff in different contexts. The other day, I was just looking at the WPA, you know, track record during the 1930s, right? Pen and paper. They didn't have logistics and all this stuff. WPA workers made 32 million visits to families in need of assistance. That included expecting mothers and one parent sick and one parent working. And it's a massive contribution to improving people's quality of life. We can do that again. Carolyn, earlier you mentioned, you know, 4 million babies born annually, right? And a lot in, you know, middle income, lower income families. And we can probably fill a football stadium with scientific studies demonstrating, you know, evidence that improving prenatal care, improving, you know, early childhood care and education pays off massively for the entire country for generations to come. That's a huge part of what we can be delivering with caring for people, caring for children, caring for the elderly. So there's millions of jobs that can be created, a small army of healthcare community workers, right, that would overlap with a lot of this. So there's the potential is plentiful. Point number two, to emphasize some of the data we've seen today, is in the Green New Deal framework, we always talk about a just transition. And a lot of people think of a just transition as, you know, something specific to coal miners, that we need a job guarantee for them so that they transition with decent jobs and benefits. But we're talking also about a just transition for the billing employees who will be out of a job, right? And that will bring efficiency to the system. That will lower the cost. So that's an important thing to remember, that when we talk about a Green New Deal, a job guarantee is not just a nice add-on to the plan. It's a core feature that applies across the entire system, not just in, you know, fossil fuel industry and so on. And then a question, an observation and a question. I'm not going to mention the person by name, but a year or two ago, I was at a conference having lunch with a participant, and we started chit-chatting, and he turned out to be a surgeon. A senior surgeon in his maybe mid-50s. So I asked him, where do you work now? And he put his head down and sort of said, I work for an insurance company. I was like, oh, that's interesting. Are you retired? Or he said, no, it just pays better, but it's very boring. So we got into a conversation about healthcare delivery versus billing and doing all the paperwork. So I asked him, what do you actually do as a skilled, talented surgeon? What do you do in an insurance company? He said, I check the paperwork. I make sure that they build the company right. And he said part of the job is to, deny coverage if it was, if it wasn't medically warranted. So that's a serious problem that we have when we have talented people who could deliver healthcare to people who need it. We take them away from healthcare delivery and we put them in an accounting office to do paperwork and to deny coverage, right?
Yeah.
So that's a big part of the reform here that will reduce cost, that will allow us to produce a much more efficient healthcare system where it's the delivery of healthcare that's the goal, not the extraction of wealth from the community that's currently the goal.
Yeah, Carolyn, how do you set that?
I wanted to put it on the table for us to discuss.
Yeah, how do you set up the competition, right? Because we're talking about for-profit hospitals, not for-profit care, including hospitals, nonprofit care, including hospitals, government care, including hospitals, including Veterans Administration. So we have this mixed bag today. And then GDP per person is for healthcare is twice as much as Switzerland for the same health outcomes.
Right. And it's almost 3 times as much for the average OECD country. So we spend a heck of a lot more money and get much less for it. So first and foremost, though, I'll say this like a broken record, is we need to fix primary care first. That's just above and beyond saying, so that people can get the basic care they need so that they don't end up in the hospital. The number of diabetics, I volunteer still as a physician. They say a doctor who's a financial planner is better than no doctor at all, right? And I work in this clinic for the working uninsured, and the number of people that we have that try to stretch drugs out and they're not taking care of their basic stuff, that they end up in the hospital because they don't have good basic care. So that's just first and foremost. And then, so the primary care, like we already talked about, you can have competition through direct primary care doctors. Now, once somebody needs specialty care, that's where, to me, we need a government payer by far that people can turn to, because that to me was the big failure of the Affordable Care Act, and we can blame Joe Lieberman for that, is that we never had a public option to begin with. And so everybody needs a public option. We need to remove healthcare from employment. It just needs to be taken away, and care is obtained individually and follows the person. And then how would you provide it? I think that's one of the issues that you're going to run into in this country, is having a public hospital versus a private hospital, to me, would create too much of a two-tier system. So all of the hospitals, to me, need to be private, but they need to be well regulated, ideally nonprofit like they do in Germany, but I don't think that's going to happen. But with the government calling the shot by paying most of the care, that'll help control the cost. The Center for Medicaid Services, they do a lot of studies on what's the best way to pay for care. So instead of fee for service, they're looking at global payment systems. So, and what Medicare does, the private insurers follow. So, I think, it's going to be hard pressed to, and I don't think it would go over well to have totally government run higher level of care institutions.
So Scott, you've looked at the jobs numbers. You may have even looked at them across countries. Observations?
I had a question on something different, if that's okay.
Yeah, go for it.
I'm curious, Carolyn, and there's a question in the Q&A that's actually similar to the one I wanted to ask by Dave Airy. I'm curious if you have any thoughts on the leverage points for dealing with this collectivist versus rugged individualist, to have the two sides have a common language that they can sort of, effectively we talk past each other in these sorts of discussions, right? Yep. Do you have any thoughts?
Well, it's very interesting because I've spoken to, gosh, well over 100,000 people, because I speak at 20 to 30 conferences a year. I've been speaking on healthcare policy for about 12 years now. And mostly in financial services, the people who attend these conferences are, of course, Republicans, right? Because that's a lot of financial services. And when I explain the need for primary care for all as a public service, everybody, oh, that's socialism. But then when I run the numbers and show, right now of the 11,000 per person per year that we're paying for health care in the United States, the government pays half of that. So through the government, we're already paying over 5,000 per person per year. And we're getting really crappy care for that. And I'm saying, if we take 1,000 per person per year and dedicate it towards providing primary care as a public service, that's a bargain. And don't you want to keep your healthcare workers, all your workers healthy? I mean, and I appeal to, since I speak with a lot of people deal with higher net worth people, your gardener, your roofer, when you have to deal with a person on an individual level who works for you, don't you want them getting good basic health care so they're not bringing sickness to you? So it's better for capitalism to at least provide basic care as a public service. And we can get into those higher level of cares. That's a different type argument. But let's start with there, because that's 70% of the care people need. And then we can make inroads on the other care. And when I say that to people, it's like, why aren't we doing this? And I'm saying Republicans, and it was very interesting. When I first wrote my proposal in 2014, I got a call from a member of the Freedom Caucus. So I actually worked with the Freedom Caucus on, can we do this nationalized community health service proposal? And their attitude at that point was not politically feasible. So I haven't talked since then. And when I talked to the other side, I've met with the far left politicians. I won't say who. It's like, oh, it's not Medicare for all, forget it. And it's like, I think this is going to take a grassroots effort. And the more people that hear it and more people that understand it, the problem is, and like you see with my fights for both the free market, nobody likes me. The free market people hate me. The Medicare for all people hate me. And I don't take that personally. So don't worry about me. It's almost entertaining to me. It's like their brains are so hardwired shut as it's the only way. Whereas, this is a great fix to help capitalism, to help our economy, to help, it provides jobs. It's a great part of the job guarantee. So many opportunities here.
So there's a problem-solving caucus now. So there's a dozen. So have you had any conversations with representatives in the problem solvers caucus?
No, I mean, because that's relatively new, right? That just started. And so I do need to reach out to them. I have not. But I'm going to keep pushing it.
Okay, keep pushing. All right, Scott, did you have more questions?
I don't know.
Okay.
Let's see if somebody else does.
I did have a comment and maybe a question for Carolyn, which is, we're talking about, I mean, a lot of this debate about Medicare for all and how to pay for it is really about the payment part. And we know from an MMT perspective, the government can and should, cover at least the low-hanging fruits, the basics, right? Right. We can debate the rest of the cost and the program. But the other side of the equation is the actual cost. And there's this assumption that there is this free market that prices things, and that's just the cost that we have to pay. And we're not acknowledging that there is a huge amount of market power and market concentration that's actually getting worse. After the pandemic, we've seen, the stress that was imposed on the smaller providers and now the big hospital systems, and they're taking over and accumulating even more market power. So we have to talk about market power in the health insurance industry. We have to talk about market power in the pharmaceutical industry, and the market power, including the American Medical Association, which controls the supply line for producing healthcare workers, right? And we have to talk about the student loan debt crisis that we have, which a lot of young medical professionals get into the system loaded with debt. So it's not just about paying for the bills and making the system more efficient. It's about taxing and regulating market power out of existence to democratize the delivery of healthcare. It's not enough to say we will pay for it. You have to, go after the price setting and the abusive pricing behavior in the system. And that in and of itself will tremendously reduce the cost, will reduce the burden on healthcare professionals, on the rest of us. And your point is extremely important to underline here, which is decoupling employment and access to healthcare.
Right.
That's just a nonsensical system that we have today. And everybody's has seen the consequences during the pandemic when millions of people lost their jobs in the middle of a global pandemic, and as a result losing their access to healthcare. So these are things that we need to address. And I think that's why this sort of extreme debate that we're having between the status quo versus Medicare for all or nothing, I think we need to dig into the details because people are just angry at the whole system and frustrated with the socioeconomic exclusion from healthcare at an expensive cost. It just, the whole thing doesn't make any sense. And that's why people are moving to the whole extreme of saying the government will pay for the whole thing and make it a human right, which I understand intuitively, emotionally, but there's so much more that needs to be done other than just paying for the program. And those questions are not even debated at the national level. I mean, dealing with the power structure. And to close this with yet another political statement about the system, which is we have to talk about the super PAC money. I mean, the people who will regulate the system, the 535 people, they're brought to you by, sponsored by super PACs.
Yeah.
And if they're not going to bite the hands that feed them. And that's really ultimately the problem that we're dealing with here.
All right, so maybe let me tee one up for like individual behavior. So Carolyn, Michael Pollan, he quoted this statistic. He said, our parents' generation had GDP of 10% for food and 5% for healthcare. So we spent twice as much on food than healthcare.
Right.
Today, food GDP is 5%. It's been cut in half. And healthcare GDP is 20%. So it went from half, healthcare being half of food to healthcare being 4 times food, right. As well as being a massive shift. So what are there in the way you think about it? Are there incentives to individual behavior, what we eat, how we exercise? Obviously people who, have accidents or diseases, we need healthcare for that. But how do we shift like that core? Because that's a major contributor to the life expectancy data that Nigel showed up front, not only for diabetes, but then also things like opioids that people get addicted to. Right.
So, the biggest determinants of health is not actually health care. It is social determinants of health. So, what's your access to healthy food? What's your access to areas to exercise? And, we've gotten into this society where it's go, 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 and people want quick and easy. So even people who have means and resources to eat healthy food and to exercise, they don't do it. And so to me, you have 2 groups of people here, those that have the financial resources and ability and choose not to, versus those who are barely making ends meet. They don't live in safe places to exercise. They're working 2.5 jobs. So exercise is a dream, and cooking healthy food is a dream. And they have food. I mean, even in my own city, we have food deserts where people don't have, and we have poor public transportation in my city, Republican-run city. Sorry, and that people can't get to places to be able to shop for healthy food. So you have these 2 camps. What are you going to do for each of those? And I think for those who are in that harder position, we need to deliver those social determinants to them. That's where community health workers would be great. Those people that choose not to, what do you do about that? This gets into a little bit. I want to talk about rationing. People talk about, oh, we're going to ration healthcare with a government-run system. We already ration. We just ration irrationally. If you don't have the money to pay, you're rationed. If your insurance company, if that surgeon you were talking about, Fadhel, said, oh, that's unnecessary, we're not going to approve it, that's rationing care. So now you have irrational rationing, and people don't understand, even if we have Medicare for all, somebody's got to decide, what are we going to pay for? And if you have, and when I was practicing emergency medicine, you have a 95-year-old coming in with a massive stroke, that the best thing to do is move her to comfort care and let her die. But the family says, no, do everything. She ends up in the ICU for 3 months at a cost of $1 million. Is that a good use of health resources? And so we have in England, they have the NICE panel, that's what it's actually called, that chooses what the system's going to pay for. And we have to decide in this country, how do we want to use our healthcare dollars? And so when you have people who have these means and they are not following what they should do, should there be some sort of extra payment that they have to make? I mean, right now we have that through the ACA in many states. For people who smoke, they have to pay more for healthcare. So there are a lot of ways you can slice it and dice it, but it's not as easy as saying, oh, everybody should eat right and exercise, because it's a different concept for different populations.
Got it.
Yeah.
All right. So
I think
to the end here. So Scott, you want to chime in, and then we'll start to wrap up.
I don't know if I have anything that profound. I do think a lot of people think of health insurance as being like, say, auto insurance or something like that, right? And having a wife with a chronic condition, that sort of thing is very frustrating. And I've even had members of my own family that I've seen, say, why should I be paying for somebody else who doesn't live healthy, or something like that? And it's obviously that's to a large degree not what's happening.
Right. The insurance, the purpose of insurance is for us to pool our resources so that we could pay for everybody that's needed. And again, to me, the part of the problem is I sound like a broken record. The lack of primary care would take care of so much of this problem. And that's why, just to provide it free, public service to everybody, so nobody's arguing who gets what. And then those higher cost issues, that's where we get into insurance being true insurance.
Yeah, but there are incentives. Like in Switzerland, if you smoke, and this happens in some insurance programs here, if you smoke, you get a discount. You save $2,000 a year by not smoking.
Right.
And so over 40 years, that's 80 grand.
Yeah.
So there are ways to combine education, general practice, access, incentives, some form of a NICE panel / death panel, as I'm sure it would be named.
Right.
Some form of collectivism / socialism, as I'm sure it would be named. But I think that's the tension here, is this like me versus we. And everybody thinks they're immune to it until it hits them or their family. And then all of a sudden it's like, hey, where's my support system? So, so Carolyn, closing comments as we wrap up today?
Well, thank you guys, one, for the work you're doing, two, for opening this conversation and opening eyes to people that there's more than just Medicare for all. And let's keep up the fight for a Green New Deal, job guarantee. I do not sound like your typical financial planner or physician, but I'm totally on board with all of the above.
Okay.
I think you're the only financial planner physician I know, actually. So
there aren't many of us. There are more than when I started. I was the second one, and now more have followed my lead.
And I think Nick's gonna post one of your white papers. You write for Forbes, so you have columns on Forbes. You have a rich website with great graphics as well. So thanks, Dr. Carolyn, and thanks, Dr. Fadhel, and thanks, Dr. Scott, and thanks soon to be Dr. Amir. for all your deep insight and wisdom today. So this is the monthly Green Jobs Report. I'm going to turn it over to Nigel to wrap up and summarize. And thanks, Nick, for keeping all the postings so people can engage. This is available for replay, and of course, share it with people who should know. Over to you, Nigel.
Fantastic. Thank you, Paul, and thank you all very much. It's been, as always, a thoroughly thought-provoking discussion, and also one where there is some hope that there are actions that could be taken that somehow might work in real life. To end, I wanted to come back to this chart or this image I showed at the beginning, where the places you want to be if you are, you want to be healthy are the purple countries, which is Canada, Europe, and Australia, New Zealand, Japan, mostly. And America is not in that group. So in healthcare terms, in this really simple metric by life expectancy, America is just not a first world country as the system currently works. And if you just zoom in on this a little bit, I've lived and worked in most of the purple countries and most of the blue ones as well. And I know firsthand there are better systems that just deliver a better result, whether it's the UK, France, Spain, Japan, the Nordic region, Australia and New Zealand. There's just a better way to do it. And I think what we've heard about today is one path that can be pursued in parallel with, some update to the Affordable Care Act, in parallel to Medicare for All. And I think it's something that is well worth us all championing. I was going to pick out a couple of things that I thought were important from the discussion amongst all of the thoughtful remarks. One was the point, community care is already there. It already takes care of 30 million people. We're not trying to start something new. We are simply trying to expand something which we know already works. The second thing is exactly that. This works and we just need to take it around the country. The other point I wanted to bring out as we wrap up is, we are on the path where many roles are being automated, including in healthcare. And you see this through automated interpretation of medical images, for example. And as jobs transition away from all of those things which can be automated, where they are going is to places with an essential human element. So this is caring for people and communication and working together, collaboration and so forth. And this is exactly the type of work that we are talking about in community care. And so I think very much fits with the trends that are being driven by the inevitable rise of the robots. So with that, I'll maybe throw it back to Paul just to introduce the episode we've got coming up in a couple of weeks' time.
Thanks, Nigel. So our next episode is on October 20th, in 3 weeks from today. And then we'll have a Green Jobs Report the week after that. Again, monthly Green Jobs Report. So our next episode is Equal Forever After, the Unfinished Work of LGBTIQ Rights. And so Rick Mordasovich of Sonoma Private Wealth and Doug Heskey of New Day Investing are co-sponsors. And then Pedro Pina from Google, Kate Kendall from the Southern Poverty Law Center, Jessica Stern from Outright Action, and Ricky Nathanson from Treat, plus others, one or two others, will join us. It will be at least an hour, might be an hour and a half. And this will be for LGBTQ month. So we're excited for this. So please sign up, share it, let everybody know. And then the week after, we'll have the Green Jobs Report. And then the following week will be the election. So we have exciting ESGX content coming up for you through the rest of the year. Please stay healthy and safe. And I thought you were look forward to continuing to educate, inform, and collaborate together. Please send any ideas that you like for future ESGXs. And of course, like us on YouTube and subscribe, as well as share and post on social media. I'm Paul Herman here in San Francisco with my co-host Nigel Lake in New York and Nick Gower in California. Thanks to all our guests today, and we'll see you next time on ESGX.